In this set of videos, I want to talk to you about two different genera that are very closely related to one another, Streptococcus and Enterococcus. Both of these organisms are classified by serology, sometimes called the Lancefield groupings after the scientist who came up with the classification scheme. And there are letters ranging from A to W. We're certainly not going to be talking about all of them because that's a lot, but we will talk about the major ones that belonging to these two genera. They also can be classified by their hemolytic patterns and, of course, their biochemical properties. The first organism we'll talk about is Streptococcus pyogenes. This organism is beta hemolytic, which is what you can see in this image over here. You've got that zone of clearance around the colony. They tend to grow in chains, which is a little bit different from staphylococcal species, which you tend to see as clusters. But again, this kind of looks like a cluster. So it's really hard to just say, oh, it's a gram-positive coccus growing this way. I know exactly what it is. You can't always depend on microscopy. Streptococcus pyogenes is also known as group A strep, sometimes abbreviated GAS. Remember, we talked about on the previous slide, those Lancefield groupings, A through W. This one is A. It has a handful of virulence factors that help with both invasion and immune evasion. We have M protein, F protein, and capsule. Those also help to block complement deposition and impair phagocytosis. So these virulence factors help protect it from the innate immune system. Group A strep also produces a number of toxins and enzymes. It produces pyogenic exotoxins, so secreted toxins that cause fever, streptolysins S and O, and streptokinase A and B that lyse cells, and then DNases that help degrade DNA. For clinical disease, the most common manifestation of streptococcal infection is pharyngitis or strep throat, where you can see the infection coating the back of the throat. If left untreated, this can lead to scarlet fever. Scarlet fever is a really rare complication that we don't see often anymore because most patients do get treated with antibiotics well before it progresses to this. And the danger with an untreated strep infection that progresses to scarlet fever is that scarlet fever can lead to significant damage to the cardiovascular system. We also can see pyoderma or impetigo, which is like what we see with staph too, kind of those kind of dry, crusty sores. It can also cause cellulitis, so a more deep tissue skin infection. That's what's shown here. And this is one of the causative agents of necrotizing fasciitis, which is sometimes called streptococcal gangrene. And so what we see here is kind of the redness and swelling, and then when it's opened up, basically all of that tissue is destroyed. And so this patient actually died of this infection. So necrotizing fasciitis is not a particular bacteria that causes the disease. It is a disease that can be caused by multiple different bacteria, and Streptococcus pyogenes is one of those. Streptococcus can also cause toxic shock syndrome, just like Staphylococcus. It releases a toxin that can overstimulate the immune system. So here we have a 46-year-old man who was scratched on the arm by his dog, and then he accidentally reopened the wound while at work the next day. The day after that, so 2 days after his scratch, he developed a fever, chills, backache, muscle pain. He showed up at the ER where there was some redness and discharge at the wound site. Cultures of wound and blood were collected. IV antibiotics were started. Within 10 hours of showing up to the hospital, he became confused and had significantly low blood pressure. Transferred to the ICU. The redness had spread. If you remember from Staphylococcus, it can cause that bullous impetigo, where basically like parts of the skin start to lift off and have fluid underneath it. They had that in this patient as well. The patient was taken to surgery. There was yellowish fluid, so basically pus and discharge and tissue death in the muscles. Cultures from the surgical site, as well as the original wound, grew Streptococcus pyogenes. The wound was debrided, so dead tissue, infection was all removed. The patient continued to decline with the development of abnormal liver function, renal failure, pulmonary distress, and cardiac abnormalities. He developed persistent low blood pressure and died 3 days after admission to the hospital. So this is basically showing how even though the infection was being treated with antibiotics, the infection was physically removed through debridement. The fact that there were the toxins in the body that caused all of those issues made it so that the patient could not recover. So we can also see with streptococcal infection that bacteremia. So the bacteria can get into the bloodstream. We can also see what's called rheumatic fever, and this is generally when a patient has progressed to scarlet fever or just untreated strep throat, and this is when patients have inflammation in the heart, joints, and blood vessels. And you can also have, as in this patient who went into renal failure, you can have glomerulonephritis or kidney infection. Now, generally, microscopy is not useful, especially for respiratory samples. So I want you to reflect on why you think that might be. Why would microscopy of respiratory samples maybe not be useful? Group A strep or Streptococcus pyogenes can be diagnosed through antigen antibody detection. There are rapid strep tests that are available in clinical settings. So if you present to, for example, like urgent care, or to your primary care physician, or even to the student health center, they should be able to do a rapid test and tell you within 20 to 30 minutes whether or not you've got strep throat. You can do culture. You'll see that beta hemolysis. You can do nucleic acid testing. And one of the other things to remember is that if you want to differentiate staph and strep, so let's say it's a gram-positive coccus, staphylococcal species are catalase positive, streptococcal species and enterococcal species are catalase negative. So I want you to think about what is the catalase test, how do you perform a catalase test, and what those results might mean. The next streptococcal group we'll talk about, or species, is Streptococcus agalactiae, or sometimes called group B Strep. By microscopy, of course, it's indistinguishable from any of the other streptococcal species. It's a gram-positive coccus. It is also beta hemolytic, so that would not be useful on a culture plate. You can distinguish it from group A strep and other streptococcal species because of its cell wall antigens, the polysaccharide capsule, and cell surface proteins. The capsule, just like with all species that have a capsule, that capsule can interfere with phagocytosis. Group B strep is a little bit different from group A strep in its preferred locations in the body. So group A strep tends to be found in the throat, upper respiratory tract. It can sometimes, of course, be found in wounds if it gets inoculated into a wound. Group B strep tends to be found in the GI or genital urinary tract. It is estimated that 10 to 30% of pregnant women carry group B strep. So if anyone becomes pregnant or has been pregnant, you've most likely been tested for group B strep, or you will be tested if you become pregnant, because this infection in neonates is very, very dangerous. So any patient who is positive for group B strep will very likely be prescribed antibiotics to help clear the infection and prevent risk to the neonate. 60% of infants born to a mother who is colonized will become colonized themselves. And the danger for that is early onset neonatal disease. So within the first 7 days after birth, the neonate can develop bacteremia, pneumonia, meningitis. The mortality rate is relatively low, but there can be a lot of significant secondary complications, especially as a result of meningitis. And that can include blindness, deafness, and even mental retardation. So the patients will have significant mental developmental delays. In patients, I'm talking neonate patients, who don't develop disease within 7 days, it is entirely possible that they could develop what's called late onset neonatal disease. And that tends to be bacteremia with meningitis. And so again, you might see those same secondary complications, including developmental delays, blindness, and deafness. In pregnant women, an untreated Streptococcus agalactiae infection can lead to things like postpartum endometriosis, so an infection of the endometrial lining, wound infection. I don't think we need to get into the nitty-gritty of childbirth, but through vaginal delivery, there can be the formation of wounds that can get infected with that Streptococcus agalactiae or group B strep, and also urinary tract infections. Other patients who we tend to see as being infected with group B strep, again, not necessarily children, but adults, these would be most often adults who are immune compromised. You may see the bacteremia, pneumonia, bone and joint infections, and skin and soft tissue infections. For the most part, in a healthy adult, the patient is able to fight off the infection. But with an immune compromised adult, with a child, so like a neonate who's also immune compromised, and even pregnant women are technically immune compromised, it can be a rather dangerous infection. So this case study describes group B strep in a neonate. So late onset group B strep in a neonate, an infant male weighing 3.4 kilograms. So 3.4 kilograms, I don't know, like 7 pounds or so, was delivered spontaneously at term. So this is not a preterm child. This is not an underweight child. This is a very average neonate. Physical examination was normal during the first week. The child started feeding irregularly during the second week. By day 13, the baby was admitted to the hospital with seizures. Cloudy cerebrospinal fluid was detected by lumbar puncture. Remember, the CSF should be clear. Streptococcus agalactiae was isolated from the culture. Despite prompt initiation of therapy, the baby developed hydrocephalus, so fluid on the brain, necessitating the implantation of a shunt to relieve the fluid and pressure. The infant was discharged at age 3.5 months. So this baby was admitted to the hospital at like almost 2 weeks old. So spent 3 months in the hospital basically with retardation of psychomotor development. So it caused brain damage. This patient illustrates neonatal meningitis caused by the most commonly implicated serotype of group B streptococcus in late onset disease and the complications associated with the infection. So again, if you become pregnant and are diagnosed as group B strep positive, like it's not that big of a deal. You don't have to worry. Just take the antibiotics that are prescribed for you. Now, the Latin name agalactiae, it basically means like no lactation. And so this is also a major cause of mastitis in dairy cattle and can cause disease in farmed fish. Of course, we're most worried about humans, but that's also possible. The infection is often diagnosed through antigen testing or PCR testing, and chemoprophylaxis, basically antibiotic therapy, is recommended for women at high risk of transmitting infection during childbirth. For the most part, if, for example, you are pregnant and have a planned C-section, there is significantly less risk. The risk is to the neonate during delivery through the vaginal canal. But if they prescribe the antibiotics, I would probably take them.